Here's a statistic worth sitting with. In recent years, researchers who analyzed hundreds of the most viewed TikTok videos under hashtags like ADHD found that a substantial portion, in some studies close to half, contained information that was misleading, overly simplistic, or just plain inaccurate when measured against clinical criteria. And yet, those same videos are, for a huge number of adults, the very first spark that leads them to ask, wait, is that me? So we have a genuine paradox on our hands. Social media has almost certainly gotten more adults into evaluation offices than any public health campaign in the history of psychiatry. And social media has also almost certainly convinced some people they have a disorder they don't have, while missing it entirely in others. Both things are true at the same time. Today we're going to sort out which is which. Let's start with what social media gets right, because it's important not to dismiss this content wholesale. That would be its own kind of oversimplification. Here's what a lot of ADHD content nails: lived experience relatability. Videos describing things like task paralysis, that frozen feeling where you know exactly what you need to do and simply cannot make your body start doing it, resonate deeply with adults who've felt that and never had language for it. That experience is real. Clinicians see it constantly, and it maps reasonably well onto executive dysfunction, which is a genuine, well-documented feature of ADHD involving difficulty with task initiation. Content about time blindness, difficulty accurately sensing how much time has passed or how long a task will take, also reflects something clinically real. Research has repeatedly shown that time perception and time management difficulties are core features of ADHD, tied to how the disorder affects working memory and executive planning. Content about rejection-sensitive dysphoria, an intense emotional reaction to perceived criticism or rejection, captures something a lot of clinicians recognize in adult ADHD patients. Even though, and this is important, it is not a formal DSM-5-TR diagnostic criterion. It's a widely discussed clinical concept used by many practitioners, but it's not one of the official symptom criteria itself. That distinction matters, and we'll come back to it in a moment because it's a perfect example of the gray zone this content lives in. So credit where it's due. Social media has done something genuinely valuable. It has put language to subjective internal experiences that used to go completely undescribed in a doctor's office. A lot of adults, especially women who were never flagged as kids, have said some version of, "I saw a video and I cried because for the first time in my life, someone described what's happening inside my head." That's not nothing. That's real clinical value, even if it comes from an unlikely source. Now here's where clinicians start getting uneasy, and this is the heart of today's episode. Problem 1. Symptom checklists presented without context. A video will list 10 behaviors. You lose your keys. You interrupt people. You procrastinate. You daydream in meetings, and imply that if you relate to several of them, you probably have ADHD. But remember from episode 1, nearly every symptom of ADHD, taken individually, is also just a normal human experience that everyone has sometimes. What makes it a disorder isn't the presence of the behavior. It's the frequency, the pervasiveness across settings, the childhood onset, and, most importantly, the functional impairment. A 15-second video literally cannot convey all 4 of those dimensions. It's not built for that. So when it's presented as a checklist rather than a launching point for evaluation, it sets people up to over-identify. Problem 2. Survivorship bias and algorithmic amplification. Platforms show you more of what you engage with. If you watch one ADHD video, you'll be shown 50 more within days, and the sheer repetition creates a feeling of, everyone relates to this, so it must apply to me, when in reality you're inside a self-reinforcing content loop, not a representative sample of clinical reality. Problem 3, and this one is subtle but important. Many creators, even well-meaning ones, are not clinicians. Some are, many aren't. They're often sharing their own diagnosed experience, which is valuable as one data point. But ADHD presents differently across individuals, and one person's TikTok about their specific experience can get generalized by viewers as universal truth about the whole condition. Problem 4. The flattening of comorbidity. This is probably the single biggest clinical concern with this content. Symptoms like poor concentration, restlessness, forgetfulness, and disorganization show up not just in ADHD, but in anxiety disorders, depression, sleep deprivation, thyroid conditions, trauma responses, and even normal chronic stress and burnout. Most viral content doesn't mention this. It presents you relate to this symptom as functionally equivalent to you have ADHD, collapsing a wide differential diagnosis into a single explanation. We're devoting all of episode 4 specifically to ADHD versus anxiety because this overlap is so common and so consequential. Let's walk through 2 real examples that show both sides of this. First example, where social media helped. Elena, 26, had spent years being told by teachers and later by bosses that she was not living up to her potential. She never struggled academically enough to be flagged for evaluation, but she describes constant low-grade chaos, losing her train of thought mid-sentence, starting 5 projects and finishing none, feeling like her brain was too loud. She came across a video describing the inattentive presentation specifically, the quiet, internal kind we discussed in episode 1, and for the first time had language that matched her exact experience. She brought it to a psychiatric evaluation, not as a self-diagnosis, but as a starting point for a conversation. That evaluation confirmed combined presentation ADHD. In her case, social media functioned exactly as it should, as an invitation to seek a real evaluation, not as a replacement for one. Second example, where it went differently. Daniel, 31, was going through a brutal period at work with a toxic manager, on top of poor sleep from a new baby at home, on top of a health scare with his father. He started watching ADHD content because he was struggling to focus, and he related to almost everything he saw. Because acute stress, sleep deprivation, and situational anxiety produce many of the same surface symptoms as ADHD: difficulty concentrating, forgetfulness, restlessness, irritability. He became convinced he had always had ADHD and just never noticed. When he eventually saw a psychiatrist for a full evaluation, the clinical picture told a different story. No childhood history of symptoms, no pervasive pattern outside this specific stretch of his life, and a clear temporal link to an identifiable stressor. What he was experiencing was better explained by acute stress and sleep deprivation, not ADHD. This is not a rare story. It happens constantly. And it's exactly why the childhood onset and cross-setting pervasiveness criteria from episode 1 exist. They protect against exactly this kind of misattribution. Now, here's how clinicians actually think about this content, because I want you to be able to do this evaluation yourself the next time you're scrolling. We ask, is this describing a specific, well-defined experience or a vague universal one? Time blindness. Specifically describing chronic cross-situational difficulty estimating elapsed time is more clinically specific than I get distracted sometimes, which describes, frankly, being a human being with a smartphone in 2026. We ask, does this content acknowledge nuance, or does it present a single symptom as diagnostic on its own? Good content says, this can be one piece of a larger pattern. Concerning content says, if you do this, you have ADHD. We ask, is this content encouraging evaluation or discouraging it? Some content, unfortunately, frames professional evaluation as unnecessary or even as gatekeeping, implying that self-identification is just as valid as clinical diagnosis. This is a serious problem because a formal evaluation exists precisely to rule out other explanations and to open the door to evidence-based treatment, which we cover in detail in episodes 6 and 7. Let's directly address the misconceptions that circulate most. Misconception 1. If a video describes my experience perfectly, I have ADHD. Resonance is not diagnosis. Many conditions and even normal human states can produce overlapping symptom pictures. Resonance is a reasonable prompt to seek evaluation. It is not, on its own, evidence of a disorder. Misconception 2. Doctors don't understand ADHD as well as people who actually live with it, so social media is more trustworthy. Lived experience is genuinely valuable, and clinicians should listen carefully to it. This course takes that seriously. But lived experience describes what one individual feels. Clinical diagnosis requires distinguishing that experience from other conditions that can feel identical from the inside. Both perspectives matter. They're not substitutes for each other. Misconception 3. Rejection-sensitive dysphoria is an official ADHD diagnostic criterion. It isn't, as of the current DSM-5-TR. It's a widely used clinical concept describing something many clinicians observe in ADHD patients, but it hasn't been formally incorporated into the diagnostic criteria, and treating it as an official checkbox symptom overstates the current state of the research. So what should you actually take from this episode? First, social media has real value in normalizing ADHD experiences and prompting people, especially those historically overlooked, toward evaluation. Don't dismiss that value. Second, symptom checklists without context, without frequency, pervasiveness, childhood onset, and functional impairment cannot diagnose anything, no matter how many times you nod along. Third, many things that feel like ADHD, stress, sleep deprivation, anxiety, depression, burnout, even just an overloaded season of life, can produce nearly identical surface symptoms. That overlap is common enough that we're dedicating an entire episode to it. Fourth, the healthiest way to use this content is as a prompt for curiosity, not as a conclusion. This resonates with me, I should look into this properly, is a great reaction. This resonates with me, so I know what's wrong with me, skips the step that actually matters. Now, here's the thing about Daniel's story and Elena's story. Both of them illustrate the exact same underlying puzzle. How do you tell the difference between something that's actually ADHD and something that just looks like it from the outside? Especially when the deeper story often starts not in adulthood but decades earlier in a childhood nobody flagged. That's exactly where we're headed. In our next episode, we're tackling one of the most important and least understood questions in this entire field. Why do so many adults, some of them brilliant, high-achieving, deeply self-aware people, go decades without anyone recognizing what was happening in their brains since childhood?